Hey everybody, it's Dr. Rob, and in today's lesson, I want to teach you how to trace a lateral cephalometric x-ray. Now, you've already learned why, because we've already looked at the why we take a ceph, but in today's lesson, we're going to learn how to trace it. I'm going to break it down into three components for you. Part one is the soft tissue profile, which part of the soft tissue that we need to trace and why it is important. Part two is the skeletal structures, cranial base, A point, B point, all of these points relating to the skeleton, because that's important as well. And then the third part is going to be tracing the teeth, the incisors and the molars, and what that means for your cephalometric tracing. So next, I'm going to take it up close. We're going to look at this trace ceph, and we're going to dissect it and break it down and teach you how to trace a ceph. All right, so we are looking here up close at my lateral ceph. Now I've gone ahead and I've traced the whole thing here. You can see if I add that tracing. I've traced it. I've traced the soft tissue, the skeletal portions, and the teeth. Now what I want to do is I want to go through and just trace everything with you so that we can teach you how to properly do the tracing. So I'll go ahead and unmark that there. Now, first thing you want to do is you want to calibrate your tracing. So this ruler right here is important because what it does is it tells me that from this point to, say, this point is exactly 30 millimeters, which means that I can then calibrate it whether I'm printing it on a piece of paper or tracing it digitally. So you have to have the ruler, which is this nose piece, down in order to properly calibrate and trace an x-ray. So that's your first step there. The soft tissue. So the soft tissue silhouette, you want to draw all along the soft tissue profile here. That's the nose all the way down, upper lip, lower lip, and then continuing that down all the way to the neck throat point. So this soft tissue is important. When you're drawing this, you don't want to lift your pen too many times. You want to make these lines smooth and aesthetic. You don't want to have different lines and gouges like that because it'll just make it hard for superimpositions later. What's kind of neat about this is if you superimpose cephs, you can see how much a patient's nose grew, or you can see how much their lips retracted over so many years, or if you extracted to retract the lips, you can see how much you retracted. Or perhaps you wanted to provide more lip support and push the lips facial. You could see what kind of changes you made there as well. So that's an important part of a tracing, is that soft tissue. Again, it's the forehead, the nose, bridge of nose, tip of nose, soft tissue, subnasally and soft tissue A point, upper lip right there, lower lip, all the way down to the neck throat point. So I'll go ahead and erase all of that there. Right? Okay, so now I want to trace the skeletal portions. So let's go ahead, and to do that, we're going to actually start with cranial base. Remember, cranial base is the most stable part of the skeleton, but really there's only a few parts of cranial base that are in fact stable. But let's go ahead and start with that drawing. So I'm going to go ahead and draw right here. And then this is that posterior clinoid process. Do you see it? You can see that right there? How it's just right there. And then here's the anterior clinoid process. And then you can see that the wall right there of sella turcica. Kind of bring that up, connecting there. And then you have that anterior clinoid process. Now remember, you have the anterior cranial fossa, right? Now there's multiple lines right here because the anterior cranial fossa is deeper in the middle and higher up on the lateral portion. So that's why that's like that. So I usually just pick the top line, which is more lateral, right there. And then the very bottom, if you continue all the way forward, you see that line right there? That line is the cribriform plate of the ethmoid bone, and where it bifurcates right here, the cristogalli. And then the greater wing of the sphenoid, you can see that right here. You can draw that all the way down, that greater wing of the sphenoid. So these are all important landmarks that you need to trace on your cephalometric tracing. Go ahead and delete that. Now, let's look at the anterior portion from the nose up. So the part that we want to trace is the labella, which is the skeletal forehead, basically, right there. And also you want to do nasal bone. And where the frontal bone and the nasal bone meet right here, that is endpoint. That's nasion. Okay? So that's all that we're really drawing above this line, is just the skeletal forehead and the nasal bone, and where the two meet, which is nasion. Alright? Like that. Now we're going to go down and we're going to trace the maxilla. How do you trace the maxilla? Well, you start at the area where the cortical alveolar bone meets the tooth. Right there. It's very, very thin. Sometimes in some patients it's super thin, you can't even see it. And then if you look really, really close, there's a little protuberance right here. That's the anterior nasal spine. And if you look really, really closely, you can see there's a concavity of how the bone is. So it goes just like that. So this point, which is the most concave point in the maxilla, the anterior maxilla, the most concave point, right here is a point, okay? Now, a little kind of random thing is everyone's maxilla has this little kind of tent projection right there that I just draw on everybody. And if you go all the way back to the palate, all the way down, the roof of the mouth, and the lingual gingival border, right here, which is where the bone of the palate meets the upper incisor. So that is our maxilla right there. Now from our head and neck anatomy, you remember your pterygomaxillary fissure right here. It kind of looks like this little teardrop that's really elongated, and everybody has it. It's an important landmark, so we trace that on everybody. And then for the teeth, you want to go ahead and just trace. What's important here really is the long axis of the tooth, meaning the very tip of the tooth and the apex of the tooth following the long axis. And that's important because we're eventually going to do a long axis line that'll look just like that. That shows kind of the long axis, so I can measure the angulation of that tooth. So that's everything for our maxilla. So we'll go ahead and erase those. Now let's go ahead and do the mandible. So in the mandible, we have the inferior border of the mandible all the way back here, the ramus, and up. And then you want to draw the condyle right there, sigmoid notch, just like that, right? Now, interesting enough is the external and internal auditory meatus. So we have the ear canal, basically, which is right here. That's known as porion, okay? And then the most superior portion of the condyle right there, and porion is the most superior portion of this circle. A little rule of thumb is this point right here cannot be above this point. So it has to be right, it's usually just right in front of it. If it were down here, then something's wrong. And if it were up here, then something's wrong. So you don't want it to be off. They're typically very close to each other. Now we have the gingival border right here where the bone and the tooth meet all the way down. And then this most concave portion right through here, that's B point. Okay, and then we draw the skeletal chin, continue along the mandibular plane up there. Now the most forward position here, which would be about right there, that is pogonion. And the most inferior point right here is menton. Okay, so those are important points. And then we have gonion right back here, which is that most inferior portion of the convex portion of the posterior mandible, right there. So those are some important landmarks. Now drawing our lower incisor, or lower one as we call it, we do the facial contour, the root. You want to try to really focus on getting just that incisor and not the other incisors. Then we can draw that line down the long axis. We want that line to be perfect down the long axis of that tooth, just like so. So that is our mandible. In our upper and lower jaw, we would also draw our molars right here. Now when you're drawing these by hand, we always use a stencil. So that way the tooth is always the same shape and size, so we can compare how the teeth move. And then we have the top molar here. Just draw like that. And then we have edge where we drew last time, so incisor there. So here's our mandible. This is all we really draw. Sometimes we'll draw the inferior alveolar canal there because that landmark doesn't really change and it's a good reference for a superimposition. So that is our mandible structures. Also, I like to draw the back of the head right through here. This area is not stable, you can't superimpose on it, but when you are lining things up, it's good to have that as a reference point. It just kind of helps you get the right inclination when you're lining everything up. So let's go ahead and erase all of this, just like so. Now I'm going to go ahead and add my tracings here, and we can go back through and look at them. So you can see I have the soft tissue silhouette. I have this important line right here. This is known as the E line, okay? This is known as the E line, and that's the aesthetic line. It's from the tip of the nose to the tip of the chin. Now this point right here is known as sella, S point. Now let's see if I can get that. So I have a dot. So if I drew like an imaginary circle where sella is, and I put a dot right in the middle, that's how we know where sella is. And where the frontal bone and the nasal bone meet, that's nasion. End point, S point. Remember the most concave portion of the maxilla, that's A point. The most concave portion of the mandible, that's B point. Now if I draw these lines in between, I can start to create some geometry where I can see these actual angles. I could actually measure this angle right here, which I could say is 80 degrees. I'd use a protractor, I'd get in there and I'd measure it very accurately. And then I'd also measure the SNB. Now you can see they're almost the same for me. In fact, B is a little bit ahead of A. So my B point is like 81 degrees. So SNA minus SNB is the difference of A and B. And that for me is about minus 1 degrees. So 80 minus 81 is minus 1 degrees, which means I am class 3, right? So these numbers are really important. It doesn't mean your patient is class 3. These are clues. This is telling me, this patient looks like they're pretty class 3. We better look into that more when we're treating them. It doesn't mean it can't be done or that that they are for sure class 3. It's just a clue. Now, where the sphenoid bone, the greater wing of the sphenoid, right here, turns down into the occipital bone, right there, this area being the occipital bone, and it goes back up to the sphenoid, back to the cephalometric. This area right here where the two bones meet, the sphenoid meets the occipital bone, that's the spheno-occipital synchondrosis, and that's where a lot of growth takes place, and it's an important part of growth and development for the face and the head and neck. So where the actual occipital bone right there and the posterior border of the mandible meet, where those two lines intersect, that's called articular. Articulari right there. And that's just an important point because you want to make sure when you're tracing these things that you're keeping it the same between tracings. Now, this line right here, this is the zygomatic arch. And in a Ceph, we call it key ridge. K-E-Y, key ridge. And it looks just like an upside down 4, right? That's how I always know to draw it. It's an upside down 4. Sometimes you'll see both zygomatic arches, so you just have to bisect the two of them. You might have like 2 lines, this and one here, and you would just bisect it. Noticing this point of the key ridge is really the bottom of the orbit where orbitali is. So here's the eye socket, and then the bottom of that eye socket, right at the most inferior portion, is orbitali. And then we have chorion, right? And if you draw a line between the two, that line is known as Frankfurt horizontal. Now, if the patient were looking up or looking down, or if they were just looking normal, straight ahead, that Frankfurt horizontal line would be basically parallel to the floor. If the patient were looking up a lot, the line would be like that. So whenever you take a Ceph, you want their head in natural head position, meaning you want them looking straight ahead. And typically, if you did a good job getting them in neutral head position, this line will be parallel to the floor. And I think it's pretty close here. Now from menton, right here, all the way up to gonion there, we can draw that line. That's mandibular plane, right? Mandibular plane. And this is Frankfurt. So this angle right here is actually called the FMA, which is Frankfurt to mandibular plane angle. What is that number? Well, for me, I happen to know it's about 29 degrees. But if my lower face were longer, that line would be down more, and this may be a steeper angle, might be like 35 degrees. Or if I had a short lower face, it might be lower, it might be like 10 degrees. So like a deep bite, short face, brachyfacial patient will have an FMA of like 10 to 20. An average would be 25. A dolichofacial or long face or adenoid face or backwards rotator, right, clockwise rotator, is going to be a higher FMA. So this is getting towards like 25, 26, 27, 28, 29, all the way up to like 30 or even 40 in really high FMAs. The higher the FMA, the longer the lower third face height can become. Does that make sense? Perfect. All right, let's go ahead and solve that there. Perfect. All right, so that is our full tracing that we did. We did the soft tissue with the E-lines. We did the mandibular plane, the Frankfurt horizontal. We did the SN, which is cranial base. SN, that's basically the floor of the cranium. We've done the SNA and SNB, which is going to tell me where the jaws are. If the upper jaw is ahead of the lower jaw, then that angle is going to be like +2, which is average, +3, +4, +5, and it keeps going. And the more the front jaw is ahead of the bottom jaw, the more class 2 the patient is. The more the lower jaw is tip to tip or beyond the upper jaw, then that is class 3. Now, if your patient's class 3, their teeth are in an underbite, right? Not necessarily. Maybe their teeth aren't in an underbite because Mother Nature has camouflaged it in such a way that the upper teeth are flared and the lower teeth are leaned back, so when they bite down, they have an underbite. But if I went ahead and put braces on, I just straightened the teeth and wasn't paying attention, I could actually push them back into an underbite, right? So that's why this angle right here is so important. So this is the upper incisor long axis, right? And here's cranial base, which is SN. So this line we call the upper 1, which is the upper central incisor, to SN line, or SN angle, I should say. So I write it like that, upper 1 to SN. For me, I know that it is about 105 degrees. Average would be like maybe 100 to about 105. If it's 106, 107, 108, that means that front tooth's getting a little flared. If it's 110, 120, that means that front tooth is really flared, right? Now the same is with the bottom, right? This line right here. So this is the lower one. And then what's this line here? Remember this line? That is our mandibular plane. So this is our incisor to mandibular plane angle. So we call that our IMPA. Incisor to mandibular plane angle. Now, for me, that number, I believe, is somewhere around like 83 degrees. Ideally, that number should be 90 degrees. But I'm class 3, right? Because we looked at our SNA and we saw that our A and B was about -1, which is class 3, right? So my front top teeth have to be a little bit flared, my bottom teeth have to lean back a little bit in order for that to work. Now, kind of a rule of thumb is, well, how much can you get away with? What if a patient comes in and they're -4 degrees A and B? That's pretty class 3. That means that my lower jaw is actually ahead of my upper jaw by 4 whole degrees. And I can't get my teeth to fit together unless I really lean back those bottom teeth and I really flare forward those upper teeth. But when I bite down, now my front teeth are really flared and my bottom teeth are really retroclined. How much is too much? A good rule of thumb is, think of like blood pressure, 120/80. So 120 on the top, 80 degrees on the bottom is kind of the maximum you can get away with. Even that, the 120, the teeth will look pretty flared. But you can get away with it functionally and periodontally. But you can't just flare it to like 150, right? Or lean it back to 70 degrees. That's too much and you can start to see periodontal issues. So that's why those numbers are so important. Another number here would be, let's look at, let's erase this though, because it's a lot to look at. So here is the tip of the front incisor, right? And then that SNA line is about, if you remember, looks like it was about right. SNA is about right here. Is a little bit behind SNB. So if I measure the distance, for perpendicular distance from there to there, that's going to be what? My tip of my incisor is about 5 millimeters beyond a point. That means the front of my maxilla is right here, and this tooth is flared beyond that about 5 millimeters. Now that's pretty normal. If my maxilla were, say, here, then what would that number be? It would be 0, right? Because the tip is right at the front of the maxilla. So we call that the upper 1, right? Upper 1 to NA, to nasion A point. So the upper 1 to NA for me is plus 5 millimeters. Now, if that number were like plus 11 millimeters, the first thing that would pop into my head would be, oh my goodness, that is so flared. That is so beyond the whole maxilla. Those teeth are just sticking straight out there. And I need to bring them back. That's going to be one of my main objectives. So if I know that number and I know 11 is excessive, then I know that's become part of my treatment plan. If that number were 0 and I had a lot of crowding, I could push it forward to plus 5 because I know I have little room to do that. +5 being about average. If it were like +8, +9, that's quite a bit up there. 10 or 11, 12 or more, then you're looking at possibly an extraction patient, or even some moderate IPR to help bring that back some. And then same with the bottom. Here's that that NB line, and then here's the lower incisor. So we have the lower one to NB. For me, might be like 3 millimeters. So my lower incisor is about 3 millimeters beyond that line, which again is normal. And if that were a very large number, like 10 millimeters, I might start thinking this patient needs extractions in order to bring that back. So those are some other measurements that we use there to help us give us clues on how to treat our patient. Let's see. So why do we trace the molars? What's the point of that? Well, we trace them in the ceph here, but we're really only using it when we're done with treatment and we're comparing a before and after, and we want to see, did I intrude the molars like I wanted to, or did I move the molar mesial to close all the space as much as I wanted to, or did I lose anchorage and maybe retract too much? So you can really just kind of see how your mechanics panned out and how it works. So this is more of to evaluate a before and after in terms of those. So it's not super important for measurements or numbers. So the cranial base we talked about in our previous lesson, the why we take a cephalometric x-ray. Part of it is to superimpose these areas right here so that we can see how the nose has grown, how the jaws have grown, how all the skeleton has changed over time in a growing patient. If we wanted to see how the teeth move specifically, you would actually not superimpose cranial base. You would superimpose just the maxilla, and then you would see how the teeth moved. And just like the cranial base has stable structures that don't change that you can superimpose on, the maxilla also has stable structures that you can superimpose on. And that's for another lesson, but we will do that down the road. And the same is true with the mandible. When you superimpose just the maxilla, you can see how the teeth moved. How much did I extrude the incisors or intrude the molars, or did I do exactly what I wanted with those movements? Erase that. All right, so I think that is everything on how to trace a lateral cephalometric x-ray. Feel free to go back and watch this a few times, because this is not one of those subjects that you can just watch one time necessarily and fully grasp. You have to practice, you have to print out some cephs, trace them, practice measuring them by hand, and once you get the hang of it, it just becomes second nature. So I hope you found that helpful, and we'll see you soon in the next lesson. Take care.